Welcome back to this next video in which we are discussing COPD. Okay, so we're just about to move on to the other component of COPD, which is chronic bronchitis. However, before we do that, let me just say something about what can happen in the advanced late stages of emphysema. So I've discussed emphysema now, I've described what it is, and we've described what is understood about the pathogenesis of emphysema in response to the chronic inhalation of this noxious gas. And we've seen that it involves the loss of this elastic connective tissue from around the walls of the alveoli and from around the walls of the respiratory bronchioles. Now, in the advanced stages of emphysema, what can happen is this loss of elastic connective tissue can get so bad that actually the entire alveolar walls start to degenerate. So remember, the alveolar epithelium and the epithelium of the respiratory bronchioles, it's sat on this elastic connective tissue. The elastic connective tissue is supporting it. And if the degeneration of the elastic connective tissue gets to a high enough level, then you can imagine that what will actually happen is the epithelium will start to degenerate as well. So what can actually start to happen in the advanced stages of emphysema is you can get alveolar epithelium and respiratory bronchioles just disappearing completely, lung parenchyma just degenerating basically, and what you end up with is cavities inside the lung, small cavities inside the lung where all of the parenchyma has just degenerated because of the loss of elastic connective tissue, and that is what supports the epithelium. So without that, the epithelium degenerates as well eventually. Okay, right, so there's a special name then for these cavities that you can see in the lungs of people with advanced COPD, and these are known as emphysematous plebs, or you can call them emphysematous bullae. So I'll just write this little term down here. So these cavities inside the lung, which are forming because the lung parenchyma has just degenerated away, are called emphysematous, so meaning pertaining to emphysema, and then you can either use the word blebs, and of course that's the plural, the singular would be a bleb, or you can use the term bullae, and again that's the plural, the singular would be bulla, so take the E off the end. Okay, so just to draw a very basic picture of this then, I'll do it here. If I have, let's say, the right lung here, literally what you will have is holes in the lung parenchyma. So you'll have little cavities like this, and they might be all over the place. And these will be certainly visible on a CT scan, and they might even be visible on a chest x-ray. So here we are, the emphysematous bleb/bullae, and strictly the definition of a emphysematous bleb or an emphysematous bulla is that it needs to be greater than or equal to 1 centimetre in diameter. So if the cavity is smaller than 1 centimetre in diameter, then strictly speaking you shouldn't refer to that as an emphysematous bulla or bleb yet. It really needs to be over 1 centimetre in order to qualify for that title. Okay, right, so that's what can happen in the later stages of emphysema then. And obviously, what will the consequences of this be? Well, you're just losing lung tissue. Lung tissue is starting to degenerate, which means that you're going to have less gas exchange. If you're losing big chunks of the lung, that's a whole chunk that would have been participating in gas exchange when it was healthy that is now lost. So gas exchange is going to go down, and that's going to make the shortness of breath even worse. Okay, so the tachypnea and the dyspnea will get worse as well. Alright, so let's now move on to the other component of COPD, chronic bronchitis up here. So, long ago now, I said that COPD consists of these two separate components, emphysema and chronic bronchitis. And remember, emphysema is the disease process that is affecting the pulmonary asceny of the lungs, whereas chronic bronchitis is the disease process that is going to affect the larger airways, so the trachea, the bronchi, and the bronchioles. And it's this chronic inhalation of the noxious gases that is causing both of these disease processes just in these two separate parts of the lung. Okay, so chronic bronchitis then now. So let me start by giving you the definition of chronic bronchitis, and then we'll talk about what actually happens to these airways in COPD to cause chronic bronchitis, and then we'll go through the actual pathogenesis, or what is understood of the pathogenesis. Right, so let me now discuss then what is the definition of chronic bronchitis. So this is a clinical definition. So the definition of chronic bronchitis is that for 2 consecutive years, so for at least two it needs to be, so at least 2 consecutive years, for 2 consecutive years, you need to have had a productive cough for greater than or equal to 3 months. So you must have had a productive cough, so that's a cough where you're bringing up phlegm, bringing up sputum, which is just the mucus that's being produced in the lungs. So if you produce a lot of mucus, if these airways produce a lot of mucus, then you'll get a productive cough. So that's already giving us some insight into one of the things that's going to happen in COPD to these airways. You're going to get a lot of mucus produced, and this needs to be present for greater than or equal to 3 months. So to make this absolutely crystal clear, if this year I had a productive cough for a period of time that was greater than or equal to 3 months, you would not be able to call that chronic bronchitis yet. If the year after that I also had a productive cough for a period of greater than or equal to 3 months, then you would be able to say that I have chronic bronchitis. So I hope that's clear. That's the clinical definition of what it means for someone to have chronic bronchitis. So let's now discuss, in this disease process, COPD, where we're inhaling these noxious gases chronically, what's actually going to happen to these airways in order to give rise to chronic bronchitis. So of course they're going to get an inflammatory response occurring in them as well, but we'll come on to that later on when we want to discuss the pathogenesis. For now, let me discuss the major effects that the inflammatory response is going to have on these airways that will lead to this productive cough 2 consecutive years for a period of greater than or equal to 3 months. Okay, so 2 changes are going to happen to the airways that are going to lead to mucus hypersecretion, so the overproduction of mucus. So one of them, and this will occur in all of those airways that I've listed, is that you'll get goblet cell hyperplasia. So we know what goblet cells are. They're those cells that produce mucin. What does hyperplasia mean? Hyperplasia means overdivision. So goblet cells are going to overdivide in COPD. So in response to the chronic inhalation of the noxious gas, maybe cigarette smoke, what you're going to get is the goblet cells that are in the epithelium of these 3 different types of airways are going to overdivide. They're going to be stimulated to overdivide. And as I say, we'll go over the theory of how, the pathogenesis later on. So for now, let me just remind you, here is a picture of either the trachea or a bronchus, and if you wanted to turn it into a bronchiole, we know you just take the 2 outer layers off. But all of these airways have an epithelium around them, and that epithelium will contain ciliated columnar epithelial cells, which we know produce the serous secretion for the mucus, and then of course also the goblet cells here in green, which produce the mucin. So we're going to get more of these goblet cells. We're going to get a higher population of those goblet cells. So that will mean that we're now chucking more mucin onto the apical surfaces of their cilia. And now what will happen is the epithelial cells will also increase their serous secretion so that overall you get more mucus. So in response to the goblet cells producing more mucin, to make sure that the mucus doesn't become far too thick, the columnar epithelial cells will increase their serous secretion, so overall you'll get more mucus being produced. So more mucin secreted overall is going to lead to more mucus being produced. So this is one of the reasons that you get more mucus now produced in all 3 of these airways, because of the goblet cell hyperplasia. And what causes the goblet cell hyperplasia, as they say, we'll come on to that. So goblet cell hyperplasia is going to lead to mucus hypersecretion, so overproduction of mucus by that epithelium that lines those airways. Okay, another thing that's going to happen, another change that is going to happen in COPD, only applies to the larger airways. So this applies to the trachea and the bronchi rather than the bronchioles. And this is that you're going to get submucosal gland hypertrophy. So this is a change in the submucosal glands, which is why it only applies to the trachea and the bronchi, because remember, the bronchioles don't have submucosal glands. So submucosal gland hypertrophy. Right, so we know what the submucosal glands are. What does hypertrophy mean? Hypertrophy means getting bigger. So this means that the submucosal glands are going to get bigger. So again, going back to my picture, here is a submucosal gland. It's a tube with an epithelium lining it that, remember, empties onto the surface of the airway epithelium. Okay, so those tubes are effectively just going to lengthen, they're going to get longer and longer, and this again means that their production is going to go up, they're going to produce more mucus, so again, this is another thing that's going to contribute to the overproduction of mucus in the airways. So the submucosal gland hypertrophy will also lead to mucus hypersecretion in the trachea and the bronchi. Okay, so what then is the overall effect of this mucus hypersecretion? Well, one of the things is that it will lead to a productive cough. So that's one of the things that it's going to cause. And by the way, just to give you some motivation for why this would want to be a response in COPD, remember we are inhaling this noxious gas for this chronic period. Why is the body responding in this way? Well, we'll see the actual pathogenesis, what's believed to underlie the pathogenesis in a moment, but just a little bit of motivation as to why the body would want to react in this way and produce mucus hypersecretion. Remember, the mucociliary escalator is there to get rid of horrible particles, horrible chemicals. So the idea is that if we can get some of the horrible cigarette smoke or other type of noxious gas to stick into this mucus, then we can get it out of the airways and therefore we can protect ourselves from it. So that's the sort of motivation for why the body would want to respond by overproducing mucus, to try and clear the horrible noxious inhalant that is coming into the lungs. Okay, so we're going to produce a productive cough. That's one of the things that you'll get with this mucus hypersecretion. And the other thing that can occur is that smaller airways can actually get completely obstructed. So you can actually get airway obstruction, smaller airway obstruction. So some of the smaller airways, so some of the bronchioles and some of the smaller bronchi, this mucus that they're producing, it can end up completely clogging up the lumen. So imagine the lumen here now completely clogged up with the mucus, and that can lead to obstruction of that airway. And of course, what's that going to lead to? Well, if you've got obstructed airways, that means that the lung parenchyma that's downstream of that airway that's blocked is not going to get ventilated anymore, so there's no air going to get through that airway anymore, which means that the portion of lung that's downstream of that, all of the alveoli that are downstream of that, they're now completely useless. So again, this is going to reduce gas exchange, and therefore it's going to lead to even worse shortness of breath, which will lead to the tachypnea and the dyspnea that we've seen before. Okay, so mucus hypersecretion then can produce these two things, a productive cough and also smaller airway obstruction. And I will just try and put in here that these are the smaller airways, so smaller airway obstruction there. Just push a little box around that. Okay, right. So that's one of the effects of COPD then. This chronic inhalation of the noxious gas is going to lead to these two changes in these airways that will lead to mucus hypersecretion, and we've seen now the two effects of the mucus hypersecretion. The final thing that I want to mention, which is going to happen to these airways in COPD, is that you're going to get fibrosis, and this is effectively the exact opposite of what happens in emphysema. So in emphysema, we've seen that you get breakdown of connective tissue, breakdown of that elastic connective tissue that surrounds the alveolar epithelia and the epithelium of the respiratory bronchioles. In the big airways, however, in the trachea, the bronchi and the bronchioles, you're going to get a very different thing happening in response to the noxious gas. You're actually going to get more connective tissue being produced. You're going to get fibrosis, scar connective tissue being produced. Now note, the connective tissue that's going to be produced is not going to be elastic connective tissue. It's going to be things like collagen. It's going to be scar connective tissue, which fills a gap, usually, but isn't elastic. So you're getting a very different type of connective tissue produced here than you would have got destroyed over at the alveoli and the respiratory bronchioles. However, it's important to note the difference between the what this inflammatory response is going to do down in the pulmonary atony and in the airways, because in the pulmonary atony you don't really get fibrosis, even though you would expect to. Where you've got this chronic inflammatory response happening down in the alveoli, you would expect to start to get fibrosis. You'd expect to have that elastic connective tissue replaced with scar tissue. However, that's not what happens down there. You don't get fibrosis, and why, I don't think is really understood at present. But certainly up in the big airways, you do get fibrosis. Okay, so fibrosis means the production of loads of new connective tissue. And as they say, this is scar connective tissue. So fibrosis is really the fancy word for producing a scar, so scarring. So replacing the tissue that's been destroyed by the inflammatory response with new tissue, scar tissue. So we're going to produce lots of connective tissue. Now, this fibrosis is going to occur in the lamina propria layer. So let me go back to my picture here. So remember, the lamina propria is this yellow layer here, the layer of connective tissue underneath the respiratory epithelium. And there will be special cells in here capable of producing connective tissue, extracellular matrix connective tissue called fibroblasts. We'll talk about those later on. And they'll be activated by the chronic inflammatory response to produce more connective tissue. So you're going to thicken this layer is the key thing. This layer, imagine it becoming thicker now. If it becomes thicker, what's going to happen? It's going to constrict the epithelium. So imagine this layer now becoming thicker. Imagine it going on down to here, and the epithelium would therefore be completely constricted in. Imagine it being pushed in, and therefore the lumen can get smaller. So this is one of the key things, key results of this fibrosis over here, that you're going to get, again, airway obstruction. So this is now also going to lead to smaller airway obstruction because the lumen is getting smaller. And even in the larger airways, you're still going to get narrowing of the lumen. So smaller airways might become completely obstructed, and I'll just go back to the pen. But in addition to that, even the larger airways are going to get narrower. So airway narrowing, I'll put there. Now, just to give you the final major symptom then of COPD, if you can imagine what happens if you narrow all of your airways, it's going to change the sound of your breathing, and in fact it's going to produce a wheezy sound. So often a symptom of COPD is wheezing breathing sounds, so wheezing. And wheezing is the noise that you're going to get in response to air being forced through smaller tubes. So when you force air through smaller tubes, that air is going to have to move faster through the smaller tubes. So let me just explain this in a little bit more detail. If we have two tubes, so here's one tube, like so, and here is another much narrower tube. If we're trying to get a certain volume of air through both of these tubes, so we've got a fixed amount of air that we want to get through the two tubes, you can imagine that to get that volume of air through this tube, it's going to be moving slower than it would have to be moving through this tube. Okay? If you're trying to get a certain amount of air through both of these tubes in a set amount of time, so you want the same flow rate in both of these tubes, because the bigger tube has a much bigger much bigger volume, then the air that's moving through that can move slower because it's got the bigger volume, the bigger cross-sectional area effectively. So, if you were to put a little membrane down the middle and count the number of air molecules that are passing through at any one moment, you get a much bigger value than if you put it here, if they were moving at the same speed. So to get the same number passing in a certain amount of time, you'd need to have these moving at a much greater speed. So let me just explain that again, because I don't think it was completely clear. So we want to have the rate of air moving through these as the same, because we're still trying to get the same amount of air out of the lungs. We've now got these smaller tubes. So if you imagine putting little membranes down the middle of these tubes, and let's say these membranes can count the number of air molecules that pass through them, okay? If we start over here, because of the much bigger cross-sectional area, sorry, we're starting with the bigger tube here, because of the much bigger cross-sectional area, these can go much slower, and you'd get a large number crossing through because of the large surface area of the membrane across that tube. So when we now go over to this one, because there's a much lower cross-sectional area, to have the same number of molecules crossing that in a certain amount of time, they're going to have to be moving much faster. So the air is going to have to move much faster through these narrower tubes, and that creates a wheezing sound. And I'll try and make one of these wheezing sounds to show you what it sounds like. So all you have to do is force expiration really fast. So if you try to force air out of your lungs really fast, you'll create a wheezing sound. So it's like this. I hope that showed up. I hope you heard that through this device, but I'm sorry if you didn't. If you want to create it for yourself, just expire as fast as you can and you'll make a wheezing sound because the air is moving at that faster rate now. Okay, so in fact, we've now been through all of the 4 major symptoms of COPD. We've talked about the fact that in response to shortness of breath, you're going to get tachypnea and dyspnea. Those are 2 of the key symptoms of COPD, and of course the sensation of breathlessness itself is a major symptom of COPD. The productive cough is a major symptom of COPD, and now wheezing is also a major symptom of COPD. Okay, right, so now let's turn on to the pathogenesis of chronic bronchitis. So we've discussed what chronic bronchitis is going to actually involve now. What I want to now see is how, in response to the chronic inhalation of this noxious gas, do you actually develop chronic bronchitis. Okay, right, so it starts very similar to how emphysema started. It's going to start with the activation of the inflammatory response. So remember, in emphysema, what had to happen is you got the chronic noxious gas inhalation into the alveoli, and this activated alveolar macrophages and alveolar dendritic cells. So the same thing's going to happen in these larger airways. You're going to have sentinel cells, macrophages and dendritic cells that are standing on guard and looking for signs that there is something wrong. And these are actually going to be present in the lamina propria here. So let me just put some of these on now. So we'll have a lamina propria macrophage here, like so, and we'll have a lamina propria dendritic cell here with its dendrites there, and it now looks like a chromosome a little bit, but never mind. Okay, so I'll just label these up. So this is a dendritic cell, which I'll abbreviate down to DC, and this is a macrophage, which for short can be abbreviated down to M, and then a phi, like so. That's a abbreviation that is commonly used for a macrophage. We've got a macrophage here and a dendritic cell. So in the lamina propria of the trachea, the bronchi and the bronchioles, you're going to have sentinel cells, macrophages and dendritic cells. And we'll refer to these as the lamina propria macrophages and the lamina propria dendritic cells. So when you're inhaling the noxious gas for a very long period of time, this noxious gas will be making its way through the epithelial cells, well, some of it will anyway, and into the lamina propria, where it will then activate the macrophages and the dendritic cells, just like it did when we were talking about the alveolar macrophages and the alveolar dendritic cells. So I'll try to actually put this onto this picture. So here comes the noxious inhalant, and it's now going to activate both of these types of sentinel cells. So this is, I'll write it down here, noxious gas of some sort. Okay, and of course the same thing's going to happen here as happened down at the alveoli. These macrophages and dendritic cells, these are going to set off the alarm. They're going to start releasing pro-inflammatory mediators. And again, it's the exact same story as previously, so I'll just go back to where we saw this previously. Here it is. So they're going to release the 2 major ones, TNF-alpha and interleukin-1, and these are going to have an effect on the capillaries and other microvasculature vessels that are in the lamina propria. So remember, the lamina propria of the airways, this is a supporting connective tissue layer for the epithelium, so it contains capillaries. So the interleukin-1 and TNF-alpha that are released by the macrophages and dendritic cells those are going to now act on those capillaries and produce an inflammatory response. So again, in this lamina propria, you will get an inflammatory exudate being produced, and you'll get the recruitment of neutrophils and macrophages into that lamina propria. Again, in response to the noxious inhalant, the macrophages and dendritic cells here will release those two special pro-inflammatory mediators, interleukin-8 and leukotriene B4, which are neutrophil chemotactic agents. Oops, I'll just go back to the bit where this is. Here we are. So interleukin-8 and leukotriene B4, which are the neutrophil chemotactic agents, and these will mean that you're going to get a lot of neutrophils and a lot of particularly a lot of neutrophils in this lamina propria connective tissue, but of course you'll also get macrophages there. So let me go back now and draw this onto our picture. Right, so we'll have a neutrophil now. So here, this can be a neutrophil that's come in as part of the inflammatory response. And then we'll have another macrophage that has come in as part of the inflammatory response. And the abbreviation that some people use for neutrophil is MPhi, like macrophages are MPhi, and there again is the abbreviation for a macrophage. Okay, so you get these brought in because of the inflammatory response initiated by the sentinel cells here. Okay, so what we now want to see is how are these cells that are now present here going to lead to the changes in the airways that we have discussed. So the goblet cell hyperplasia, the submucosal gland hypertrophy, and the fibrosis. So let's start off with the goblet cell hyperplasia and the submucosal gland hypertrophy. So it's still controversial, it's not set in stone that this is the reason that this happens. However, one of the major theories at the moment as to why the presence of the neutrophils and macrophages in the lamina propria chronically is going to lead to goblet cell hyperplasia and submucosal gland hypertrophy in the bronchi and the trachea is the release of the same proteases that we saw in emphysema. So I remind you, neutrophils, I might just put this on here, so I'll zoom in. So remember, neutrophils, they release a whole bunch of proteases, neutrophil elastase, which we'll abbreviate down to NE, cathepsin G, which I'll abbreviate down to CATG, and also matrix metalloproteinases. And these were the ones responsible for breaking down the elastic connective tissue in the alveoli, underneath the alveoli and around the respiratory bronchioles. Macrophages, meanwhile, they also release neutrophil elastase, and they also release members of the matrix metalloproteinase family, different members to the ones that the neutrophils release. So MMP is there. Okay, right. So it's believed that these same proteases which break down the elastic connective tissue around the alveoli walls and around the respiratory bronchiole epithelium, they're going to lead to the goblet cell hyperplasia and the submucosal gland hypertrophy up here in the airways. And it's believed that these proteins, and remember they are just proteins, they have the enzyme function which allows them to break down the elastic connective tissue in the pathogenesis of emphysema, but they are just proteins. It's believed that they are actually act as signaling proteins, and they activate receptors on the basolateral surface of the goblet cells on the epithelium up here, and also on the basolateral surface of the cells of the submucosal glands, and trigger the activation of cell division, which leads to the goblet cell hyperplasia and the submucosal gland hypertrophy. Because remember, in order to get the submucosal glands to grow, you need the cells that line them to divide. So specifically, it's believed that they activate the receptor called the epidermal growth factor receptor. So I'm just wondering where to put this. I'll get another colour. We'll have blue. So on the basolateral surface of the goblet cells, in fact, actually, this isn't going to show up very well, so I'll go over and start afresh over here. So let's just quickly draw a goblet cell. So this can be a goblet cell here, like so. Here's its nucleus, and as always, I'll have it sitting on the basement membrane just to give us orientation to which side is which. So here's the basement membrane down here. So the lamina propria would be underneath here. Okay, right. So it's believed that these proteases released by the macrophages and neutrophils activate a receptor on the basolateral side of the goblet cells, and this is the epidermal growth factor receptor. So I'll just draw this here. So here is this receptor on the basolateral surface, and this is representing the epidermal growth factor, the EGFR receptor. So writing this out in full, E is for epidermal, GF is for growth factor, and then the R is for receptor. So this is one of those receptors that can induce cells to divide. It's a growth factor receptor. So it responds to growth factors which are trying to get cells to divide. And this receptor is specifically named because it responds to the epidermal growth factor. Okay, so it's believed then that these proteases, so neutrophil elastase, cathepsin G, and members of the matrix metalloproteinase family, are capable of binding to this receptor just like epidermal growth factor would, and activating it. So activating it to dimerize. If you remember the epidermal growth factor receptor, if you ever studied cell signaling, this receptor here is a receptor tyrosine kinase, so it will dimerize with another one, then you'll get autophosphorylation, and then you'll activate signaling pathways like the RAS, REF, MEK, ERK signaling pathway, or the PI3 kinase, AKT, mTOR pathway, which promotes cell division. But the important thing for us to understand is that once that receptor is activated, it results in proliferation. It activates the cell to divide. So this is all starting to make sense then. We have this chronic inflammatory response in the lamina propria where we're getting lots of these neutrophils and lots of these macrophages present there for a very, very long time. We know that these are going to be releasing these proteases over a very, very long time, and now we think that these proteases are activating this growth factor receptor on the basolateral surface of these goblet cells, and that's what triggers the goblet cell hyperplasia. So I will just put a little question mark here because it's not set in stone that this is the reason, but this is a very elegant explanation that a lot of people put belief in. Okay, right. So the same thing then is believed to happen to these cells that line the submucosal glands. These same proteases will make their way down to the submucosal glands and activate epidermal growth factor receptors on their basolateral surfaces, and then trigger those cells to divide, and that results in the submucosal gland hypertrophy. Okay, right, so I might just, well, we've explained that now, so the next thing we want to come on to is the other thing that happens in the COPD pathogenesis of chronic bronchitis, this fibrosis, this production of more connective tissue in the lamina propria, so lamina propria fibrosis. Now this has a separate mechanism involving the macrophages, so it's the chronic presence of the macrophages that is believed to underlie this. So these macrophages that are going to be present in the lamina propria now for a very long period of time due to the noxious gas inhalation, these are going to release a new player, a new signaling molecule that we haven't talked about before, and this is called transforming growth factor beta, a very famous signaling molecule that macrophages release. So I'll just, I'll go out and put it over here. So the big player in producing this fibrosis is believed to be TGF beta, and this stands for the transforming growth factor beta. And this is a very famous signaling molecule. This is the one that always activates scarring. So wherever you've had chronic inflammation, the macrophages start to produce transforming growth factor beta, and this is the thing that activates fibroblasts, the cells that are in all tissues and which produce extracellular matrix, to start producing much more, to set up their production big style and produce lots of new tissue which will produce the scar tissue. So this is, a famous molecule that activates fibrosis. The big mystery in the pathogenesis of COPD is why the macrophages down at the pulmonary acini don't seem to activate fibrosis down there. This is far more classical. Usually when you have chronic inflammation, you do get scarring. Okay, so this is an expected response to this chronic inflammation in the lamina propria, whereas the lack of this down in emphysema is mysterious. Okay, right, so what will happen then, going back to our picture here, I need a fibroblast to complete the story. So in the lamina propria, we're going to have fibroblasts, which have this sort of shape, a similar spindle shape to the smooth muscle cells. And what will now happen is transforming growth factor beta will bind to transforming growth factor beta receptors on the surface of the fibroblast. And let me just write down this thing's name. So this is a fibroblast, a cell that can produce connective tissue fibers. And once the transforming growth factor beta receptors on the surface of the fibroblast have been activated, it will start producing connective tissue. It'll start spitting out connective tissue, and this will result in fibrosis. It will result in this lamina propria becoming thicker and thicker and thicker, and that will result in the epithelium moving in and in and in, the basement membrane moving in and in and in, constricting the lumen of the airway. And this is going to happen in the trachea, the bronchi, and the bronchioles. And for the smaller airways, like the bronchioles and the small bronchi, this can result in complete obstruction. Remember, we've also got the mucus hypersecretion, so the two will work together to obstruct airways, which will lead to worse gas exchange, more shortness of breath. And even in the larger airways, you're still going to get narrowing, and that will lead to a wheeze, because now the air is going to have to move faster. Okay, right. And there, I believe that now covers what I know and what I wanted to say about the pathogenesis of chronic bronchitis. So again, the chronic inhalation of the noxious gases sets up a chronic inflammatory response, particularly involving neutrophils and macrophages. And I'll remind you that if you go to more advanced textbooks, they will tell you about all sorts of other weird and wonderful immune cells that are brought in to the lamina propria in the pathogenesis of COPD. The two absolutely major ones, if you're just going to learn the core ones, are the neutrophil and the macrophage. So for a basic understanding of COPD, know that neutrophils and macrophages come into the lamina propria, and also the connective tissue around the alveolar epithelia and the respiratory bronchiole epithelium. Okay, this chronic inflammation in the lamina propria, it is what triggers the goblet cell hyperplasia and the submucosal gland hypertrophy, and that's believed to be through the proteases that the two types of cell release. And the fibrosis is, as fibrosis always is, triggered by the macrophages releasing transforming growth factor beta that activates fibroblasts. And this is normal. I'll stress that again. It's very normal that where you get a chronic inflammatory response, you get fibrosis, the production of scar tissue. The lack of this down in around the alveoli and around the respiratory bronchioles is what's mysterious and what we don't understand about the pathogenesis of emphysema. Okay, so we've now gone through the pathogenesis of chronic obstructive pulmonary disease. We divided it up into these two different components, emphysema and chronic bronchitis. Emphysema is the effect of the noxious gas on the lower portions, so the pulmonary acini, the respiratory bronchioles and the alveoli, whilst chronic bronchitis is the effect of the noxious gas on the larger airways, the trachea, the bronchi and the bronchioles. Okay, both of these places you're going to get this chronic inflammatory response, and this leads to the damage to all of these different places in the lungs. And remember, the major symptoms of COPD are that you are breathless, which leads to you breathing too fast, so tachypnea, and having to breathe laboriously, which is dyspnea. You also have a productive cough because of the overproduction of the mucus, and we understand why you might want to actually have that as part of the response to the smoke, because hopefully it might stop some of the damage. It might protect the airways from these horrible chemicals in the smoke. And then finally, a wheeze because of the narrowing of the airways due to the fibrosis, and also because of the oversecretion of the mucus. That's also going to narrow the airways, so that's what leads to the wheeze. Right, so we'll end this video here. In the next video, what we will go on to is discussing acute exacerbations of COPD, and then after that we'll discuss the treatment of COPD.